The sound that you're hearing is a harsh inspiratory sound, and this is stridor. Stridor is a medical emergency. So always be aware of stridor, and stridor occurs because of obstruction above the larynx or in the pharynx. It occurs because during inspiration, negative intrathoracic pressure occurs, and this draws in air from the mouth into the larynx with great velocity, and because of obstruction there is turbulence. This turbulence leads to generation of pressure waves as shown here, and these pressure waves exit from the mouth and they lead to the generation of sound waves. Classically, it is during inspiration, but sometimes it can be during expiration or biphasic. If at the level of the glottis or below the glottis till the suprasternal notch is the presence of obstruction, then it is biphasic. If it is within the interthoracic trachea or the bifurcation of bronchi, then the stridor is expiratory. It is important to realize that stridor is not only inspiratory, though mostly it is inspiratory. Expiratory stridor has to be differentiated from audible bronchi, and it occurs in expiration in these situations because the lung is being forced out during expiration, and as the air exits from the lungs in the thorax with great velocity, there is narrowing of the airways also in expiration, so the obstruction gets compounded. Must also realize what are the causes in the ICU. Post-extubation laryngeal edema is the most common cause, and if you are thinking there is possibility, always do a cuff leak test before extubating the patient. Then if you cause a cervical hematoma while putting a central line because of coagulopathy, it can compress the airways, and the patient can always come from outside as per the causes listed here. The diagnosis of stridor depends on the CT, chest and neck, and also on bronchoscopy. The treatment involves many modalities depending on the cause, but for post-extubation laryngeal edema, give 4 mg to 10 mg dexamethasone IV, nebulize with racemic epinephrine 1 ampule every 20 minutes as required. If that is not available, use the usual epinephrine, give NIV support, and get ready for intubation. If there is no improvement in the next few hours, 30% of the patients will require intubation. If intubation not possible, then give a tracheostomy.